Hello, everyone. Welcome back again. So let's continue our discussion today. We will have Dr. Ruma.
Yes, ma'am.
Yeah, okay, just 1 second. I will move the slides. Section number 6, okay. Okay, so now we have the case here. You will have 2 minutes reading time, formulate your answer,
Yes,
and then 10 minutes to discuss the case, okay?
Yes,
I will start the 2 minutes now for you.
ma'am. Any more slides? Yes, Dr. Ruma, if you are ready. Yes, ma'am.
Yeah, you can start.
Hi, I'm Dr. Uma, one of the doctors in the gynecological clinic. Can you confirm me your name and age?
Hi, Doctor. I'm Alexia Shon. I'm 65 years.
How may I address you?
Alexia is okay, doctor.
Okay, Alexia, I have gathered from your notes that you are recently diagnosed with ovarian cancer stage 3, and you are here to discuss your management options. Is it right,
Yes,
Alexia?
doctor. Yes.
Do you have any more concerns, and what are your expectations from today's presentation, Alexia?
I don't have any questions, doctor, apart from what about the options available for me? And
Yes,
the end, doctor? Is it the end of my life? This is my main concern.
Yeah. I can understand your worries, Alexia, and it's very understandable that you are upset. But we are here as a team to help you, and we will make a management plan for you. So don't worry. Okay, Alexia, before proceeding towards the management option, can I ask you a couple of questions? Then we will make a safe management plan,
Yes,
and
doctor, sure.
I will also provide you patient information leaflet. Is it right, Alexia?
Okay, doctor.
Okay. Alexia, can you tell me more about your problem? That how it was started?
Yeah, actually,
How
doctor,
what?
yeah, like
Mm-hmm.
3 months ago, doctor, I started to have like feeling bloated and I feel something wrong in my tummy. So
Mm-hmm.
I was thinking it might be the bowel or anything. And after that, I went to the GP and he offered me the scan at the start and another blood test. And
Mm-hmm.
at the time, it was the diagnosis. And then they offered me another, a lot of investigations and blood test imagings to be done. And then they
Mm-hmm.
referred me here just to know what about the options available for me.
Mm-hmm. I'm very sorry to hear, Alexia, about your problem. You really had a tough time. So, Alexia, I want to ask you that do you have any family history of cancer?
No, doctor.
And Alexia, do you feel any problem in your water work?
No,
What about nausea, vomiting, Alexia?
no, doctor.
Alexia, are you up to date on your cervical smear?
The last one, it will be this year, doctor. I think it's
Okay,
due in 2 months, something like that. I cannot remember the exact date.
okay, Alexia. And Alexia, can you tell me, do you have children?
Pardon, doctor?
Do you have kids?
Yes, doctor.
How many, Alexia?
3. They are grown up.
Okay. Was it normal delivery?
No, doctor, it was cesarean section.
And okay, thank you, Alexia. And what about your menstruation? Was it regular?
Pardon, doctor, can you repeat again for me the question?
Alexia, I want to ask you, how's your menstrual cycle?
No, I don't have any periods now, doctor. I'm 65. It stopped,
Okay. When you,
yeah,
yeah.
it stopped like
When
15 or 15 years ago.
okay, Alexia. Alexia, so are you using any treatment like HRT?
No,
Okay, Alexia. And Alexia, I want to ask you that are you using any contraception?
no, doctor, I don't have any periods. No.
Okay.
Now, doctor, or in the
Alexia,
past, you mean?
okay, Alexia. Alexia, do you smoke?
No.
Pardon me asking about any recreational drug and alcohol.
Alcohol, occasionally, doctor, yes. For the drugs, no.
Okay. Okay, Alexia. Alexia, are you well supported at home?
Yes,
Are you allergic to any medication, Alexia?
no.
Uh, Alexia, do you know your BMI?
It's around 32, doctor.
Okay. And what's your blood group, Alexia?
It's A positive.
Do you accept blood?
Yes.
Okay, Alexia. Thank you very much for letting me know all the information. Do you want to add something?
No, doctor, thank you.
Okay, Alexia, I want to examine you in the presence of Chevron, your BP pulse temperature, and your tummy. Is it all right?
Okay, yes, all right, doctor.
Okay, thank you very much, Alexia. Alexia, coming towards your management plan. So, uh, I want to tell you that first of all, we will create a team of expert doctors, which will contain my consultant gynecologist, okay, Alexia, and sleep doctor, and cancer doctor, and blood doctor, and psychological counselor, and a nurse, a specialized nurse in who will take care of the cancer patient. Are you getting me, Alexia?
Yes, doctor, I'm following you.
Okay, okay. Then, Alexia, as it is your stage 3 cancer, so first of all, after evaluating from sleep doctors, we will plan a surgery for you. In this surgery, we will give a scar in your tummy and then in your tummy, and then we will remove your womb, your ovary, your tube, and we will take sample from the adjacent tissue and your fatty layer. Okay, Alexia, and
Yes,
then uh, we will take sample and then we will close you, and then we will do uh, a, uh, a treatment for you, which is treatment of drugs, which will chemical drugs, which will kill your cancer cells. Are you getting me, Alexia?
yes, doctor. Yes, doctor,
Okay,
I'm following
Alexia?
you. Yeah.
Okay. That will we will have the cycle of this treatment, and in medical terms we call it chemotherapy, which will contain cancer medicine, which will kill the cancer cell and stop them from growing and developing more. And
So, doctor, this treatment, it will be with the surgery, or it's like instead of the surgery?
Alexia, in this stage of your disease, we will do the both things. First of all, we will remove your womb, uterus, and tubes, and then we will give you this therapy to kill all the cells and
Okay.
kill all the cancer cells. And we will also do your some investigation like MRI and chest X-ray and CT chest to know the spread of this disease in your body. Are you getting me?
Yes, doctor. And
And
doctor, for how long I will use this treatment?
Alexia, you have to undergo this treatment for 6 months, and
Mm-hmm.
6 months, and then you will I will connect you to the cancer doctor, and he will follow you.
Okay.
Okay, Alexia. Okay,
Yes.
Alexia, and I want to ask you that for your anxiety and as you are upset, you told me, so I will connect you to the psychological counselor, and he will do some talking therapy.
Yeah. Okay. Yes, doctor, please.
And I will also provide you a nurse, a specialized nurse in cancer, who will take care of you. Are you getting me?
Yes, doctor.
And
Is there any other options, doctor? And what about the effect of this treatment for my condition? Is there any cure of my cancer or not?
Alexia, it would be decided by our specialized doctor team, and we hope that you will be cured by this treatment.
Okay, one more question, doctor. Sorry for that. I read on the internet that there is another way to give the medications, like through the tummy. So is it effective, doctor, or not? And is it available or not?
Alexia, I will talk to my consultant about your this medication which you are asking me, and I will let you know.
Okay.
Okay. And I will providing you patient information instead, and please go and read and come back to me after making your plan of surgery. Thank you very much. Thank you for your time.
Thank you, doctor. Thank you so much. Okay, well done, Ruma. We will fix some points here in this station, but very well done. I feel it's like a start for yourself. So very well done. We need just to have like arrangement of the information gathering. I will tell you in a minute, but I will tell first the good points. Your introduction, excellent. Setting the agenda, excellent. Your situation awareness, and you know that where are you, and also you know that the patient, she knows her condition and she's here today to discuss her management options. So very well done. You get this point. No breaking bad news here because already the patient knows, so you didn't do it. Very well done. You asked about cervical screening, safety point, drug allergy, transfusion concerns, or the patient accept blood or not. Very well done. It's all safety points. What else here? You examine the patient, and then explanation. You can ask the patient, had someone or has someone discussed with you what is the meaning of cancer of the ovary or not? If no, so discuss. If yes, okay, go to the next step, which is the management, and you did it. You involve multidisciplinary team. You highlight to the patient the surgery and the chemotherapy. So very well done. So overall performance, it was good. You covered most of the points, but in between these points, we have some missed points. Okay. My first advice to follow even your own template, okay? Not a special template like mine or any other mentor, but use your own template in all the stations. What is the aim of that? So you will not forget anything important, okay? Like here, medical history, surgical history. You asked the patient about the menstrual and the patient is 65. You asked her after I said, I don't have a period. So you asked about the contraception. So if you have a template in your hand, you will know that this patient here, postmenopausal, I will not ask about this. You can ask about the menstrual, you know how? You can ask about when was your last period, like when was the menopause? You can ask, it's not important question, but you can ask, still you can ask if you have time. So this is my first advice for you, to follow a template so you will not miss any point. So let's go with the detailed feedback. But as I told you, overall performance, you covered everything, but you need to rearrange things again and to remember the missed points. Introduction agenda, I don't have any problem. The patient here to discuss the management options. She was diagnosed with ovarian cancer. Information gathering. Here you start to ask about your first question was family history. This is a point, Ruma. So what we can do here, we have to follow the template. Start with the history of the present illness so you will not miss anything. So how is this story or your problem start? Tell me more about your problem. So the patient will start to say, I have bloating and I feel something wrong and I went to the GP, the story. Then ask her about, is there any pain with this bloating? Yes or no? If no, skip. If yes, analyze. Do you have any itching from down below or in down below? Do you have any bleeding, like even spotting? Do you have any lump in your tummy or lower tummy? Okay. So if yes, analyze. If no, so go to the next step. One second, please, guys. Then the personal history. So for the personal history, We have also the red flag signs, and you asked about the urinary symptoms. Nausea and vomiting, yes, you can ask, but it's not the important point. The urinary, the bowel, loss of weight, loss of appetite, and pain, bleeding, lump if it's not in the history of the present illness. Then personal smoking, you ask it about. Alcohol, recreational drugs, but don't ask like double question. It's very important here also, guys, that don't ask double questions. Why? Because the patient will answer yes or no. So here I said it's yes for alcohol, but no for drugs. Okay, so it's better in the exam to ask one by one. The BMI of the patient, yes, you asked about, and it's 32. So what is the risk here? This patient, obese, 3 cesarean sections. And with this obesity, the risk of DVT will be more. So you can even highlight the DVT as a risk here, risk of surgery. Drug allergies covered from your side. Very well done. And it's a patient safety point. Cervical screening covered. What is the aim here? The patient is 65. I told you that it's due this year, but I cannot remember the date. What is the importance here, guys? Just brainstorming, because now in the exam, they will have like, little tips in the exam just to see how to comment on that. So the patient 65 and she will go for surgery. Please offer her cervical screening before surgery, just to know what about, or even colposcopy if you have anything suspicious in the cervix. You got my point? So this is the aim of the question, or to ask about the cervical screening. Okay. Obstetric covered. HRT covered. You asked her, did you receive HRT? It's better not to use abbreviation with the patient. So ask her, do you or did you receive any hormonal treatment? Like this, okay? So this is another tip here. If you are following the template like that, you will not forget any point. You got my point, Ruma? So just make your own one. Just make it like in a sequence. So you will jump smoothly from one question to another, very smooth, and you will not consume time. Then medical. Do you have any medical problem of concern? Are you on any regular medications and it was missed from your side? Do you have any surgeries done in your tummy or down below before? Do you have any family history of concern? No, doctor. Any history of breast cancer? No. Ovarian cancer? No. Cancer of the womb? Bowel cancer? No, doctor. Sexual, you can ask, are you sexually active or not? And this blotting or this problem affecting your sexual life, it's plus or minus question here. So you can ask or not. Mental, very important, and it was covered from your side. What about support at home? So here you miss the medical and surgical. So if you are following this, yeah, make it like in sequence. Then just say, thank you for sharing this information with me. Do you want to add anything? No, doctor. I'd like to examine you in presence of chaplain, or I'd like to offer you examination, because the word offer, it's more polite even, guys, because offer means the patient can accept or refuse. So I'd like to offer you examination in presence of chaplain after your permission. Is it okay? Yes, doctor. Then thank you for your time. And then coming to your concern. Here the patient knows her condition, but she knows, or did someone discuss with her ovarian cancer? If yes, okay. If no, very simple explanation, presence of abnormal cells in the ovaries. We do have 4 stages for that, and highlight also the importance of the stage. The stage mean, how about the growth of the tumor or the cancer, and what about the spread to any organ inside your lower tummy or tummy? And when we will give your cancer a stage, it's very important because it will help us in the treatment. So some options will be available, some options will not be available according to the stage. Stage 1 and 2, it's early ovarian cancer. Stage 3 and 4, it's advanced ovarian cancer. And unfortunately, guys, 7 patients out of 10 will present with stage 3 or 4, especially for the ovarian cancer. And why? Because the ovary, it's organ inside the pelvis. It has room around it. So it will grow more and more. The patient will not have symptoms unless it's advanced ovarian cancer. This is the problem of the ovarian cancer, especially this cancer, especially. Okay, so 7 out of 10 will present in stage 3 or stage 4. How in layman language discuss the stages? I included here one slide in layman language, and this is what we will use in the simulated patient task, like our patient. And we have another slides for the stages from the cancer research with details. But this other slides we will not use in the simulated patient task because it will be advanced for the patient to discuss with her, like 1A, 1B, 1C, and then 1C, 1C1, 1C2, 1C3. It's very advanced. But just have a look on it if you want. If you want just to remember part 2, and just to keep it in your mind if we will have a structured discussion. Okay, so if we are here in the simulated patient task, we will use the layman language. So we do have 4 stages. Stage 1, the cancer in one ovary or both ovaries, or in the tube connecting the womb to the ovaries. Am I clear so far? Yes, doctor. Stage 2, the cancer in one or both ovaries and spread to other organs, but still it's in the pelvis, it's in your lower tummy, like involvement of the womb, the water bag, or the bowel. Stage 3, the cancer, 1 or 2 ovaries or fallopian tubes, the tubes, and it spreads outside the pelvis to the lining of the tummy, which we named medically the peritoneum. If you will tell any medical jargon in the exam, guys, yeah, very important point I remembered here. So if I'm by mistake, I told the patient involvement of the peritoneum, which is the lining of your tummy. So explain the jargon, you are safe now. Or make it like reverse, the lining of your tummy, which we named it medically the peritoneum. Or any lymph nodes nearby. Stage 4, the cancer has spread outside the tummy to distant organs like lungs or liver. This is stage 4. So stage 1, you can also here draw one ovary or both ovaries. Stage 2, it will spread, but within the pelvis, so it can be in the uterus, the womb, the bladder, the bowel. Stage 3, it's spread to the lining of the tummy, which is the peritoneum. Stage 4, away from the pelvis or the lower tummy, like involvement of the lung or liver. And also use drawing here, it will be good and it will enhance the marks in the communication. The prognosis, famous question. And usually, guys, this is the main question. If you are in your clinic, the first question, I will live or not? Will I die, doctor? Even the patient can ask you about the time, how many months or how many years I will live, okay? I will live, sorry. So the patient, this is the main concern of the patient, okay? So to know the prognosis here, especially in the ovarian cancer, it's a little bit difficult to predict or to tell the patient. We need more tests. We need to check the test results, the type of the ovarian cancer, and the type will not be in our hands except after the removal of this ovary or the cancer and sent to histopathology, the type of the ovarian cancer. The genetic factors, some of the patients will have genetic factors which will make the cancer ovary more aggressive. And likelihood response to the treatment, and it's different from one patient to another. We will not say this patient will respond, this patient will not. No, it's different, and we cannot predict as well. Factors such as age, fitness, overall health, like patient with any comorbidity like diabetes, hypertension, any heart disease. So this patient will not respond well, or the complications will be more in this patient. Yes. So the prognosis will depend on many things. So to be safe in the exam, the patient will ask you about the prognosis. She will live or not, she will die or not. So it's very difficult. I'm so sorry. It's very difficult to answer this question because it will depend on many factors like your age, some genetic factors. Your body will respond to the treatment or not. You are fit or not. Do you have any other medical problems or not? The type of the cancer itself, we don't have any idea about the type until we will remove it and we will send it to the lab to be examined under microscope. And all the test results, like the blood test and the scan, the imaging like the CT scan and so on. Okay, here this is for your knowledge. Epithelial cells, if it's epithelial cells and it's cancer stage 1, 1 second please guys. Hello, sorry guys for this interruption. Yes, I asked just for 1 second. I'm back now. Okay, so let's continue. So this is for your knowledge, guys. Epithelial cancer, if it's stage 1, it has a very good prognosis. Okay, so if it's epithelial and stage 1, it will have very good prognosis. Many cases or more advanced cancer may respond well to the treatment, but it often comes back. Okay, and further treatment is needed. So this is the epithelial. If it's stage 1, very good prognosis. If it's advanced, so usually it will respond, but it will come back, and further treatment will be needed. For the stromal cell, germ cell tumors, usually it's treated successfully, and there will be a small risk of the cancer to come back and need further treatment. For the borderline tumors, usually it's treated successfully with surgery only. Okay, guys? So this is it's for your knowledge. You will not tell the patient epithelial, stromal, borderline, but in case of we will have any structured discussion or special question from the patient, or you have the histopathology if the treatment done or the surgery done for the patient. So if the MRCOG will make any changes, we will be ready for that. The management has to be with the multidisciplinary team. And here you mentioned that, Dr. Ruma, group of expert team, they will sit together to discuss your case, all the results, like blood result, the scan, and they will come to the best option for you. Coming to the options we already have. We have the surgery, chemotherapy, radiotherapy. And as you can see here, like cervical cancer, I will tell the 3 options, and then I will tell the patient, this option suitable, this one no. And I will show some differences here. So the surgery or chemotherapy or radiotherapy. And here, guys, for the ovarian cancer, usually the first option will be the surgery, plus or minus chemotherapy. For stage 1 and some cases of stage 2, you can offer only surgery. Stage 3 and 4, some cases of stage 2, you have to offer chemotherapy. And I want from you here, guys, to mention the 2 types of the chemotherapy, either adjuvant or chemoadjuvant, or neoadjuvant chemotherapy. So the adjuvant, and you covered this, Dr. Ruma. I asked you how many, for how long I will use the treatment or the medication. You mentioned 6 months, yes, or 6 cycles, because the cycle usually it's 3 weeks. So 6 cycles or 6 months, it will be good also. We have a new adjuvant, and it's advised now, guys, to use the new adjuvant. How to use the new adjuvant? You will give the patient chemotherapy 3 months to shrink the size of the cancer and also to kill any distant metastasis or cells, and then to have the surgery in between, and then again 3 months chemotherapy. So chemotherapy, surgery, chemotherapy. What about the adjuvant? This is the old one, surgery, and then 6 months or cycles chemotherapy. Which one is the better or the best? This one, neoadjuvant. They found that the outcome is better, side effects and complications of the surgery is less. Okay? So the neoadjuvant is better than the adjuvant chemotherapy. What about the chemotherapy? And it's not important at all in part 3 to remember the name here of the chemotherapy. Mainly we are using two agents here, paclitaxel and carboplatin together. So this is the two agents we are using in the ovarian cancer. Treatment of the stage 3 ovarian cancer. This means the cancer has spread away from the ovary, like our patient. Okay, the main treatment will be surgery and chemotherapy. And you covered this, Dr. Ruma. Treatment can cure some cases, some advanced cancers, but the risk of recurrence will be higher. Okay, but if the treatment cannot cure you, the aim to control the cancer. So here it's not like the cervical. Do you remember in the cervical? I told you it's aggressive, and usually to cure it's only in stage 1, the early stages. Here, still, even with the advanced, but it's some advanced cases, and it will depend on many things. The type, the age, any comorbidities like we mentioned. But even if it will not cure, we will control the cancer. And the specialist doctors here or the team in the MDT will discuss your case together, and they will come back with the final results. What about the best option for you? Okay. You can highlight this again for the patient where the cancer has spread, and if the consultant oncologist think that they can remove all of the cancer, this is the aim. And what about your health? The factors will affect the decision by the end. Chemotherapy after the surgery, this is the adjuvant. It will be 6 cycles after removal of all the cancer cells, and we will give you the chemotherapy to kill any residual cells or any other distant mets. This is the adjuvant. The neoadjuvant, you will tell neoadjuvant is a medical jargon. So for the patient, you're going to say giving you chemotherapy before and after, which we medically named it neoadjuvant chemotherapy. 3 cycles, surgery, 3 cycles. It's better with the outcome and also less complications of the surgery. After the surgery, you will have the rest of the course of the chemotherapy. This is a neoadjuvant. When you will speak about the surgery, don't forget to highlight the risk. Do you remember your question, Rika, in the previous case? Our famous line, infection, bruises, bleeding, injury of any organ inside your tummy or lower tummy, like the water tube, the water bag, the bowel, any blood vessels, bleeding, blood transfusion, or even death. Okay, risk of or complications of the anesthesia. What about the complications or risk of the chemotherapy? So explain how it will work. It will kill the cancer cells. However, while it will work on the cancer cells or abnormal cells, it will kill the normal cells as well. Or it will affect the normal tissue, like to have a lower level of your blood, anemia, mouth ulcers, feeling fatigue or tired, feeling unwell, nausea and vomiting, and the most important and concerning point, loss of hair. And at that time, please, here in the ovarian cancer, you have to highlight this to the patient. We can discuss how you can manage or how we can manage this. Shall I proceed, or do you want to discuss it later? No, please, doctor, proceed. So we do have many options or things to be done before giving you this medication, the chemotherapy. You can also highlight that chemotherapy is given in arm, so you can tell, and some of the chemotherapy will be tablet, but mainly it's in arm. So for the hair, we can offer you a cooling cap. You will wear it while receiving the chemotherapy or the medication. It will cool the skin over your head, which we named it the scalp, and it will reduce all the blood going to your hair. And by reducing the blood, it will reduce the dose of chemotherapy going to your hair. So it will reduce the hair loss. This is the cooling cap. You guys, so this is the cooling cap. cutting hair, the patient can cut her hair before the treatment, and it's a very good option. So the patient will not feel like it's because of the treatment. Sorry guys for this interruption. Just I will turn on my device again. So coming back to the chemotherapy, I will discuss it with you until I will turn on the other device. So for the cooling cap, the patient will use while she's receiving the chemotherapy. So at that time, the blood going to the scalp and going to the hair will be less. So the dose of chemotherapy will be less, and this will reduce the blood loss. The second option for the patient to have or to cut her hair before receiving the chemotherapy. And how it will help this, it's just psychological, guys. The patient will not feel it's because of the chemotherapy, I'm losing my hair. So at that time, she will be a little bit satisfied. Sometimes even one of the family members, like her husband or brother or sister, can also share her with cutting the hair. So she will feel herself not strange or I'm odd, I'm losing my hair. Using the synthetic hair, the NHS can pay for that. So just 1 second, guys. I think my device now is ready, so I can share the screen. I'm sorry for that. 1 second, please. Or 1 minute. 1 minute, please. Okay, guys, sorry for this interruption. Yeah. So we have to counsel also the patient about the wig. So if the patient asked you about this, we do have two types, the synthetic one and the natural one. The synthetic one, it's funded by the NHS. So the NHS will pay for that. But if you want or you need the natural one, so you have to pay for that. Okay? So it's very important to counsel the patient because it's a question in the exam. The patient will ask you about the hair loss, especially because this is the main concern of the patient. Here we have some slides. I told you at the start, we have one slide for the stages in a layman language. And my advice to use it in the exam because it's not wise to tell the patient about the stages like from the cancer research. Our source here is a Cancer Research UK. But it's for your knowledge and if you will have any structured discussion. So stage 1, simply the cancer in the ovary, either 1 or 2 ovaries, or in the tube. So cancer 1A, it's 1 ovary. 1B, it's both ovaries. Cancer 1C, we have 3 groups. Cancer 1C or stage 1C, it means that there is rupture of the capsule. Okay, but when this rupture happens, here 1C1, it means it's in 1 or both ovaries and it's ruptured during surgery. So during surgery, so that's why it's 1C1. 1C2, it's burst or rupture before surgery. Okay, 1C3, it's in 1 or both ovaries, and the cancer cells, we found this in the fluid taken from inside your abdomen during the surgery. So any fluid we can find during the cytology, we can find the cancer cells in the fluid. This is 1C3. So 1C1, rupture during surgery. 1C2, before surgery. 1C3, you can find the cancer cells in the fluid from the abdomen. Okay, guys? So this is stage 1A, 1B, and 1C. Stage 2, it means that the cancer has grown outside the ovary, but still it's inside the pelvis, okay, within the area of your hip bones. Or if you are in the exam, it will be better to tell lower tummy. It's easier. We can divide it into 2A and 2B. 2A, the cancer has grown into the fallopian tubes or the womb. And in the RCOG, they considered the fallopian tube stage 1 from the website of the RCOG strategy. Stage 2B, so here we can tell like 2A, it's spread to the womb. Stage 2B, it means that the cancer has grown in other tissues in the pelvis, still in the pelvis, such as the bladder, the bowel, like rectum or sigmoid colon. And we have the picture. You can use this picture to draw exactly like this in the exam. Okay, but with little information, like using the first slide of the layman language. So this is stage 2. Stage 3, and it's a little bit complicated, so we will not complicate things, just to have to highlight the important points here. Stage 3, it means that the cancer has spread outside the pelvis to the lining of the abdomen, which is the peritoneum. Okay, and we will have like microscopic spread, macroscopic spread. So that's why please use as simple as you can. For stage 3A, we have to classify it into 2 groups, 3A1, 3A2. So 3A1, spread to the lymph nodes in the back of the abdomen. 3A2, we can see that the cancer cell spread to the peritoneum, okay, and also in the lymph node. It might be plus or minus lymph node. 3B, so this is 3A1. Look here, microscopic spread of the peritoneum. 3B, the growth 2 centimeters or smaller in size in the lining of the abdomen or in the peritoneum. So what is the difference of 3A2 and 3B? 3A2, it's microscopic. 3B, it's macroscopic, but it's less than 2 centimeters. Okay, guys, and it might be in the lymph node. 3C, here it's in the lining of the abdomen, the peritoneum, but it's more than 2 centimeters. So from the ovary, if you can see here, spread to the lining of the abdomen, which is the peritoneum, and it's more than 2 centimeters, plus or minus lymph node involvement. Okay, so this is stage 3C. Stage 4, here distant metastasis, but we will reclassify it into 2 groups. 4A, it's pleural invasion. So as peritoneum, but here it's the pleura around the lungs, not the lungs, guys, and take care of this mistake. So it's in the lining of the lungs. We called it pleura if you will discuss with the patient, but I'm pretty sure it's very advanced, very, very advanced to discuss this with the patient in the exam. And usually the patient will present with pleural effusion. And when you will take sample from this fluid, the effusion, you can see the malignant cells inside it. Positive cytology. 4B, it's spread to the lung itself. So now it's not the pleura, it's the lung, the liver, or any other organ. So this is stage 4B, which is the advanced stage of the ovarian cancer. And as I told you guys, these slides, just for your knowledge, just to have an idea, not to search back to see what about the difference in between stages. You have here all the stages, but it's not important to remember in the exam, just the first slide, the layman language, how to tell the patient about each stage. Okay? Then to finish your station, give the patient information leaflet, set another appointment with the consultant, and contact the multidisciplinary team. Here, don't write to the don't write back to the GP. She's not referred by the GP. Already she was diagnosed with ovarian cancer and the process is going. So just contact your consultant, contact the multidisciplinary team, attach her to support group, a counselor to help her how to cope with her condition, and that's it. Okay? So that's all what we have today. Do you have any questions in the ovarian cancer? Any questions, guys? Is it clear? Okay. You're welcome, Dr. Rika. You're welcome, Dr. Sunita. Thank you so much. Okay, guys. Thank you so much. Okay, so we're gonna stop here. I wish this session today was helpful for all of you. If you have any problem with any station, we can just drop a message on the group, a case discussion, or direct message to arrange another session to discuss if we have any hot topic or any recent recall or new station, so we can discuss it together. Okay, guys, thank you so much. Thank you for your attendance today. Assalamu alaikum wa rahmatullah.